Hi everybody, it's David Porter, LADC. Today's topic is management of chronic pain if you have a history of chemical dependency. If you have a history of dependency on opiates, alcohol, cocaine, amphetamines, benzodiazepines, you are at risk for developing dependence on other psychoactive substances, whether they're illicit or prescribed. It's called cross addiction, and it is indicative of the AA expression that a drug is a drug is a drug. In other words, while people have preferences, individual preferences for different substances, all psychoactive substances, that is, a drug which will alter your thinking, your emotions, your perception, your behavior, and produces a dopamine reward chain. That is, it releases excessive amounts of dopamine in a part of the brain called the nucleus accumbens, which is regarded as or been identified as the pleasure center of the brain. It creates a chain of events called the dopamine reward chain. That was good. That felt really good. Don't forget how good that felt and repeat the behavior. Boy, that was good. Don't forget. Do it again. Dopamine is the neurochemical responsible for both pleasure and reward, and it is also involved with memory storage. So you get the pleasurable sensation that gets stored into your memory, and then a desire to repeat the behavior and relive the experience. So if you have a history of dependence on one substance, you are at risk for dependence on any other psychoactive substance. But you have a conundrum here. What if you are suffering from chronic pain? What if you have an injury and you're going to have short-term pain to deal with? Opiate analgesics have a very high probability of triggering dependence on a new substance, or if you have a history of opiate dependence, it has the potential for reactivating your addiction. So here are some alternatives to discuss with your doctor. And the first thing I have to say ethically is I have to stay in my lane. I'm an LADC, licensed alcohol drug counselor, a sub-doctoral clinician. And while I've done a lot of research into neuroscience and psychopharmacology and taught course sections in those topics, I am not a physician. I am not a prescriber. So I am not giving medical advice. Rather, these are some ideas to discuss with your prescriber. These are things to discuss with your physician and/or your pharmacist. By the way, everyone, don't overlook pharmacists. Don't forget pharmacists as a great source of information about meds. Pharmacists love talking about meds. They are a great source of information. If you have any questions regarding your medication or options for over-the-counter medications, or again, things to discuss with your prescriber. So here we go. The first, I think the first line choice for an analgesic, that is, it's a pain-relieving medication that's free of psychoactive properties, will include ibuprofen and naproxen. Ibuprofen, marketed under brand name Advil and many generics, is available over the counter, and it is an NSAID, a non-selective, non-steroidal anti-inflammatory, also referred to as a non-selective cyclooxygenase inhibitor. And ibuprofen and naproxen and aspirin have similar mechanisms of action. What they do is they prevent the production of a substance called prostaglandin. Prostaglandin is made when you injure cells. When cells are injured, they produce a chemical called prostaglandin. Prostaglandin hands a message off to substance P. Substance P sends a message upstairs, up the ascending pathways in your spinal cord, right up here actually, to what's called the parietal lobe, which contains the sensory motor cortex. That's where we perceive pain. And that substance P hands a pain message off, or rather, prostaglandin hands a pain message off to substance P, travels upstairs to the sensory sensory motor area of your brain where you perceive pain. And also, typically, you're also going to get inflammation. Prostaglandin inhibitors, ibuprofen, naproxen, and aspirin are going to prevent the production of prostaglandin, so you break that chain of biochemical events, so the pain message can't get upstairs to your brain and the inflammation message can't get upstairs to your brain. Another option is Tylenol, acetaminophen, brand name Tylenol. All meds have two names, at least two names. They're brand name and they're generic. So acetaminophen, brand name Tylenol, is another option. Tylenol is an anti-inflammatory and an analgesic. However, it will not reduce fever. It's not an antipyretic. Ibuprofen, aspirin, and naproxen are all antipyretics. By the way, major difference between ibuprofen and aspirin. Ibuprofen is a stronger anti-inflammatory than aspirin. Naproxen is a longer acting anti-inflammatory than ibuprofen. Tylenol or acetaminophen works in a manner which is not well understood. It does something probably in your spinal cord with what are called interneurons. These are the pain gates that either send the message, admit the pain message upstairs to your brain, up the ascending neural pathways to your brain, or close the gate and say, nope, the pain message isn't coming through. Superior analgesia can be achieved with a smaller dose of ibuprofen and a small dose of acetaminophen combined. Once again, please do not do this until you have spoke to your physician or at least a pharmacist. These are ideas to run by your doctor. I'm not giving out, not telling you what meds to take. Other options include transdermal lidocaine, a lidocaine patch. Lidocaine is a quick-acting, short-duration local anesthetic. It comes infused into an adhesive patch which you place close to whatever is hurting or on whatever is hurting. And ideally, you're not going to go numb. Just a little bit of lidocaine is going to seep in through your skin and give you analgesia without anesthesia. That is, it's not going to cut off sensation. Lidocaine is short-acting, but when it's in a transdermal patch, you get a lot more endurance out of it because you're going to get a short-acting medication released very slowly over a period of hours. Another option, it may be a TENS unit. I always want to say T is transdermal. That's not right. Transcutaneous electroneural stimulation. This is a device about the size of the Canon PowerShot camera that I'm making this video with, or even smaller. It typically clips onto your belt or your waistband, and then electrodes are placed on whatever part of you is hurting, and you adjust the controls, and it basically sends a electrical charge into which basically transmits an electrical charge which interferes with the pain message. The pain message traveling from the hurt area up the ascending pathways to the sensory motor cortex are a electrical transmission. So a counter signal is put up by the TENS unit which blocks the transmission and prevents you from feeling the pain. Other options are topical patches or topical rubs, that is gels or lotions or creams, ointments containing either menthol or capsaicin or both. Menthol is an extract from the peppermint plant, and it is going to activate the cold receptors on your skin. It's what's called a counter irritant, where it's going to you're going to feel the cold instead of feeling the pain. Also, it has a very strong camphorous smell. You're going to get a little bit of sensory distraction to compete with the pain message. A little bit. So that's something else that, again, this stuff is typically purchased over the counter. Discuss it with a pharmacist. The other counter irritant and more is capsaicin. Capsaicin is an extract of chili peppers, of hot peppers. and it's going to activate what are called vanilloid receptors, that is heat receptors in your skin, so that you feel a sensation of heat and warmth instead of the pain. So it's very comforting. And again, it may have, depending on the product, it may have a strong smell. You're going to get a little bit of sensory distraction, but it's also going to have a secondary action. Those heat receptors in your skin are going to start dumping out the aforementioned substance P, because they're going to be reacting like your skin is burning. It's not. You're just getting those vanilloid heat receptors activated. They are going to pretty rapidly run out of substance P. They're going to downregulate. Your brain is going to get the message that, okay, your skin's not on fire, let's calm down and let's shut down production of substance P, which means that pain signal is not going to make it to your brain. Another very important component, last thing I want to talk about, is if you have a condition like arthritis, fibromyalgia, bursitis, tendinitis, you're not going to want to move. You're going to want to lay down and take it easy, but that's actually one of the worst things you can do, because now you're going to be focusing and concentrating on the pain. You're going to be excluding other sensory input, focusing on the pain. If you lay around too much, you're going to gain weight. Every pound you carry is more pressure on your joints. You're going to reduce production of the synovial fluid, which is the joint lubricant, and you're going to get stiff. Your muscles are going to atrophy, and you're not going to have support for those injured joints. And you're just going to become demoralized and discouraged and may feel hopeless and you're not going to be able to do the things, or you think you're not going to be able to do the things that you're accustomed to doing. And that's depressing. That's how people spiral downward into depression. You've really got to get up and exercise. Light exercise, never put an injured joint through full range of motion, but you work as you do as much as you can. And now, one more time, you're probably sick of hearing this, do not start any exercise program without talking to your physician. You may need to hire a personal trainer and see, so that, or you're maybe already going to PT, physical therapy, so you can learn how to do movements, whether it's stretching, whether it's just putting a joint through a range of motion, walking, getting in the pool and doing some hydrotherapy, swimming or wading or moving, put paddles on your arms and just wade in the pool and move against the water resistance for exercise. And you also have the advantage of buoyancy, the water taking the stress off your joints. So you talk to either your doctor, a physical therapist, or a good personal trainer, and see what you can do within the limitations of your body. And it's going to prevent that cycle where your pain is going to be focused on, your body is going to start to break down, and you may suffer further injury, and you can get very depressed that way. So, everyone, those are some of my thoughts on pain management. I want to thank you for watching, and please feel free to leave something in the comment section, and please hit subscribe. Be safe.